Welcome to today's Power of Knowing webinar, The Death Experience Part 1. Understanding comes from knowing, and the diagnosis of a progressive or terminal illness can create a crisis for patients and families. This two-part webinar will explore the physical, emotional, and spiritual impact of illness on patients and family members from earlier stages of illness up through death and bereavement. This free webinar series is called The Power of Knowing, was created by AuthoriCare Collective, which empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanau. Risa serves as clinical and community educator at AuthoriCare Collective and is also a member of the Cone Health Ethics Committee. She is a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It's my pleasure to introduce our panel for today. First, Whitney Blaylock. Whitney is a hospice home care social worker for AuthoriCare Collective. She is a licensed clinical social worker. Whitney has worked with us for over 2 years and has worked both in our hospice program and our palliative care program. She has a passion for healthcare and values the interdisciplinary team model. Stan Massey. Stan offers 40 years of brand improvement and marketing expertise. He has worked on improving internal communications as well as creating marketing strategies and campaigns for more than 50 senior care providers. In addition, Stan was the primary caregiver for Paula, his wife, prior to her death. Misty McAden. She is currently a hospice chaplain with AuthoriCare Collective. She has been providing spiritual and emotional support to hospice patients and their families for over 8 years. Misty has a Master's of Divinity degree and is an ordained Quaker minister. In addition to providing support to those facing life-limiting illnesses, she is experienced in leading grief support groups, workshops, and individualized counseling. Allison Raber. Allison is a registered nurse certified in hospice and palliative care nursing. She has been with us at AuthoriCare Collective for nearly 5 years and has had multiple roles within our nursing program. She currently is a hospice home care case manager. Allison helps families to anticipate and understand end-of-life changes and provides them with the knowledge and training to best care for their loved ones during this difficult time. And Victoria Thompson. Victoria is a Greensboro native. She is an RN who received her BSN at UNCG here in Greensboro. Victoria joined us at AuthoriCare Collective in our hospice program in 2018 and is a long-term care clinical manager. Victoria is passionate about caring for patients at the most vulnerable time in their lives. Welcome all. Thank you for joining us for this conversation, and thank you for the participants who are joining us both on Zoom and Facebook. For those of you on Zoom, we have a polling question. We'd like to get to know a little bit about who is joining us today. You can see it on your screen. It is multiple choice, and you can select as many as apply to you because we know that many of us serve in many different roles all at the same time. And the poll is anonymous, so we appreciate you taking a moment to answer all that apply to you. And once we take a moment, that lets us have a good sense of who is joining us, recognizing that some of us are probably checking every box on that screen because we know that oftentimes we have, yes, multiple roles. As we look at that, we see that we have a really large group of caregivers and advocates and healthcare professionals and human service professionals, and also spiritual care guides joining us. So thank you for participating in that poll. We appreciate that. And we also invite you to make use of the question and answer area on the Zoom screen at any time during our conversation. And we will try to answer as many of those questions as we can during our time together. So to get us started, Stan, I think the best place for us to start is if you could tell us about Paula, your wife, and your shared experience with her illness.
Thank you, Risa. My wife, Paula, died of complications from non-Hodgkin's lymphoma in March of 2013. And I know that everyone's journey during a serious illness or a terminal illness is different, but I wanted to share the Cliff's Notes version, at least, of Paula and my journey, because I think there are some common areas that this very expert panel can address based on my story. In 2007, we were very surprised when Paula was first diagnosed with lymphoma, and she underwent successful chemotherapy that actually put it into remission for 4 years. And then all of a sudden it came back with a vengeance. From that point on, it really was a downhill slide over a period of 2 years. One of the things that really struck me is, in addition to the physical challenges, there's obviously a lot of emotional challenges with a serious illness. Paula was only 51 years old when she passed away. So she was 49 at this point where it came back. And there obviously is a lot of sadness, there's fear, there's grief. And I think it's fine to admit that Paula had some anger, not at any person, but kind of at the universe, because you would not meet anyone who lived a cleaner lifestyle than Paula. She ate very clean. She didn't drink alcohol. She didn't smoke tobacco. She exercised regularly. She was the picture of health on the outside, but inside the lymphoma was spreading. So there was a lot of anger to deal with, and not in a pity, why me way, but she really couldn't intellectually understand why this was happening to her. And it was genetic, but there was that anger issue. And I think a lot of families probably experienced that. During her decline, she got progressively worse, and you saw my credentials. I've been working for hospice and palliative organizations for 20 years, and you won't find a bigger advocate for all the benefits that hospice and palliative care can bring. But Paula did not want to give up curative care, which obviously is a prerequisite for going on the hospice benefit. And I had to respect that choice. We kept trying progressively more aggressive treatments. None of them were successful. Fortunately, we lived in the Toledo, Ohio area at the time. And fortunately, our local community-based hospice provider actually had a palliative care program. And so we were able to take advantage of that and get some support and some counsel and some guidance while Paula continued her curative care. As her condition worsened, I just wanted to focus for a second on the family caregiver role. We were empty nesters. I was obviously just living in the house with her myself. I was very fortunate because her very best friend lived right next door to us. And her best friend from junior high on happened to be a CNA. So during the day, I had support of two wonderful, strong women helping to care for Paula. But I was trying to go to my full-time job and then come home and be the primary caregiver overnight. Any of you that have gone through that experience knows that it can really be exhausting. It is a labor of love, but you sleep with one eye open and one ear open, and you really get very little sleep. It really does affect your day-to-day. I came across a term several years ago in my work that I thought was just so accurate for people in this situation. It was called presenteeism instead of absenteeism. I was physically present at my office, but man, my mind was often a million miles away. And I had obligations that I had to take care of during business hours, as far as doctor's appointments, getting prescriptions refilled or renewed, or lots of things. So it really did affect my job performance, and I had very understanding employers. So that whole side of being the family caregiver and me not having to be in that role before, being thrust into that, to have the support of a palliative care organization was really, really valuable. As Paula's disease progressed, not to be too graphic, but lymphoma is a very liquidy cancer. It got into her spine and spread, and it cracked a couple of her vertebrae. So all of a sudden, she had these physical needs. She had to be in a clamshell type brace to even get out of bed. She was on a walker. She really needed to have a hospital bed, but she wasn't yet a hospice patient. Because of the palliative care experience and because of the increasing obligations of the caregivers, friends and family, Paula finally agreed to sign on for hospice care. One part of the story that I wish were different, because I work with people and I help tell people all the time to get involved with care as soon as you can. When Paula was finally ready to sign on as a hospice patient, she had signed the agreement. And it sounds dramatic, but I guarantee you it's true. She signed that agreement, and the nurse from the hospice organization left her house. 20 minutes later, she had a pulmonary embolism and died 36 hours. But because she had signed on as a hospice patient, I actually spent one of my briefest times ever in a hospital ER. An ambulance came and got her. We didn't know what was wrong. They quickly diagnosed it. The ER doc was very accurate. She said, I think she has 36 to 48 hours to live. We were able to transport her within 30 minutes to a beautiful hospice inpatient facility, which was the perfect setting for friends and family to come say their goodbyes. None of that would have been possible without the support of palliative care first and then hospice care. And there's so much more that hospice and palliative care providers can do to support family caregivers in their roles. There is much for the caregiver as they are for the patient. And it's just tremendous work that this team does. And I guess that really is the highlights of my experience, and would love to turn it back over to Risa and the panel for discussion.
Thank you. Thank you, Stan, not only for sharing Paula's story, but also for really framing our conversation for today and for next week. So Whitney, I'm gonna ask you, since as I mentioned, you have worked in our palliative program and you have worked in our hospice program. If you could talk to us about both of those programs, when is most appropriate for palliative care and then for hospice care, and the support, as Stan mentioned, that is available both to patients and to the family and the caregivers.
Yes, thank you. And thank you, Stan, for sharing. I think you kind of capture what that experience, what we would like for that experience to look like for our patients in terms of palliative care, then hospice care, and then, obviously having the inpatient care as an option. So we offer both of those services, palliative care and hospice services. And they look a little different, and I think they can be confused, used interchangeably, but they're different. Most of the time, folks have similar diagnosis. We'll see a lot of folks with cancer, dementia, stroke, liver, kidney disease, congestive heart failure, a range of things that we see. But it's kind of where in your illness do you fall for which program would be most appropriate. For hospice, a physician will certify that, if this illness continues to run its natural course, that in 6 months or less, they predict that, a death would occur. And that's no curative treatment, like Stan mentioned. And that's when someone would be eligible for hospice services. Palliative care is a little different. It may be at the start of an illness that someone can begin with palliative care services and maintain that. And really the focus of palliative would be bigger picture conversations. You can still have curative treatment and be a palliative care patient during that time. And I want to point out that both of those programs can meet patients wherever they are, whatever you consider home. So that could be a private residence, a nursing facility, a retirement community, anywhere that you consider home, both of those programs can see patients. So what do these programs provide? Like Stan mentioned with the visits from the team, our hospice team is much more interdisciplinary, kind of a whole team of professionals that are seeing you more frequently. And that can range from the nurse, the social worker, the chaplain, our hospice aides, and then your physicians. You've got an attending physician and a hospice physician. And you also have volunteers and grief counselors. They are considered a part of the team as well. And typically you're seeing these people more frequently, a few times per week. And then as Stan mentioned, we also have our inpatient facilities for that's more for end of life, few weeks left to live. We think someone's transitioning or actively dying. Then we have our inpatient facilities as an option for our hospice patients. Palliative care is a little less comprehensive. It's more of a consult service. But like I said, it's bigger picture. So you have our nurse practitioners that are involved, and they're assessing your symptoms, making suggestions for care, recommendations, helping to have conversations about advanced directives. What are your goals? How can we support that where you are right now in this illness, and how this will look as things progress? So lots of education, and then a bridge into that, into those hospice services when that time is right. And so I think both of those programs, very similar, but very different. And the focus of both, though, is to relieve symptoms, to provide comfort, support, to meet you and your patients and families where they are, and improve quality of life overall, no matter where you are in your illness.
Thank you. Thank you for that. And I want to turn to Allison. With your nursing expertise, we know that when somebody has been diagnosed with a progressive and potentially terminal illness, we know that they are undergoing changes. And if you could talk to us some about those changes, the physical changes that might be occurring for the patient and that the family and caregivers might be observing, and some signs that a patient is declining as they are coping with whatever their diagnosis is.
Okay, thank you, Risa, for having me and allowing me this opportunity to share my knowledge and experience. This is my passion. I'm going to speak from the perspective of a home care hospice nurse. And like not Wendy, who was right before me? She had mentioned hospice.
Whitney.
I'm so sorry. I don't work with her enough. When a person comes to hospice, they have exhausted all their options, with curative treatment, whether it be radiation, chemotherapy, if it was cancer, or their, other disease processes. Their immune system has become weaker because up to this point, their immune system has kept their disease at bay, whether it be with the additional curative treatments or just the strength of their own immune system. So when they come to us, that immune system's starting to get a little bit weaker. I always tell my families, you have to look at it like there's a little battle going on inside, and it's the disease process and their own immune system. So when they're with us, that disease process is starting to get a little bit of the upper hand, okay? And that's going to lead to a person start to see a significant functional decline and generalized weakness. So when I say generalized, it's going to be like, oh, I just don't feel like myself. What's going on? I'm just so weak. I can't do anything. And it's really going to affect someone. They live their whole life doing the things they love. And then all of a sudden they're too weak to do them. So that's going to bridge into the other topics and conversations about the emotional and spiritual aspects of things. But at that point, that patient is probably going to sleep a lot more than they had been sleeping because they're weak. They've got that battle going on inside of them, and it's exhausting. And they're going to sleep more. And you realize that every little thing we do in life requires energy. And you don't really recognize that until you're in a position like some of our patients typically are. So they're going to sleep more. And when they're going through that, they're going to kind of be more withdrawn from loved ones and family because they're self-reflecting. They're trying to figure out, first of all, what is going on. Okay. And then they're taking a moment to look back at their life. Okay. As they become weaker, I always tell my families it's that weakness that's leading their journey. And it kind of helps them understand a little bit more about why are they becoming weaker. And I can explain each step based on that. So their appetite is going to become decreased. They're not going to really want to eat much. We eat every day, the ones that are fortunate enough to be healthy, we eat every day to build up an energy reserve to get us through our busy days. When the patients are weak and they're sleeping more, they don't necessarily need all that energy. So they don't need that food as much. So the body's also going to trim down. The body looks at eating. It takes energy to eat. The act of eating, chewing, swallowing, digesting the food is going to take up some of that energy that the body is needing internally to fight that battle. It's got to keep that immune system focused on keeping that, trying its best to keep that disease process at bay and focus on the main core functions of the heart and the lungs and the core things. Swallowing, like I said, it takes a lot of energy, but also as a person gets weaker, swallowing is composed of a lot of muscles and movements. So that weakness is going to affect the swallowing. The person's not going to be able to swallow and have the help of the body pushing things through. So they're going to realize, okay, this is scary. I'm swallowing, but it feels like I'm going to get choked up. And that kind of contributes to them not wanting to eat as much either, because it is a scary feeling. They might start to choke on drinking liquids. That's what we see first. They'll drink a little bit of liquid and be like just really coughing immediately, because our swallowing mechanisms also help regulate how much liquid goes down our throat at one time. But when it's weakened, you swallow something, it's just all going to go down and you didn't plan on that. So the regulation of that is kind of diminished too. So a person would start to choke from that. Again, everything that takes energy and strength, even the breathing, okay? It could get to the point where a person's breathing becomes very shallow. And families, it's scary. I mean, all of this is scary. They want to feed their loved ones. They want everything to continue the way they were. And that's where I jump in and help them understand what's going on. So when a person starts breathing very shallow, I explain that they're too weak to really expand those lungs fully. And because they're breathing shallow, several other things can change. You may see changes in the vital signs. Their heart rate might get a little bit faster, trying to help out that respiratory system. It's not getting that oxygen everywhere. Which could lead to anxiety, could lead to shortness of breath. It's very cyclical. And from that, you could also see skin changes because the oxygen, if it's very shallow, it's not getting oxygen everywhere. I know patients, they all recognize when you get with a nurse or a doctor, they're putting that thing on your finger, and we check your oxygen level on your finger for a reason. We want to know, is your body allowing oxygen to get everywhere? So this is the furthest away point. So we'll get to a point where we see it may not be getting there as well as it should be. It's getting oxygen, but it's not, as much as it was before because the body is focusing on the core. Okay. So the hands may become cooler in temperature. The feet may become cooler in temperature. The skin changes maybe include color changes because the cardiovascular, that's a muscle, is getting weaker too. So it's going to pump away blood, but it's going to have trouble getting it back because it's fighting against gravity. Gravity is going to keep that blood, that unoxygenated blood, at lower points. So you might see a little discoloration in the skin at different locations. You might see temperature changes. A person may be really feeling hot and warm, and my family's like, oh no, they've got a fever, and they might have a little bit of a fever, but it's not the same as a fever that you or I would get based on bacteria or an infection or something. I always say it's that battle, our body's fighting. And when that disease process is getting the upper hand, we're fighting even more. So that temperature is going to get a little higher because it's fighting. And then your body's going to say, "Oof, I need a break. I'm tired. I got to rest a minute." And you're going to see a lower body temperature. And that, what I just said, explains a lot of it. It appears like a roller coaster. It's hard to understand because our bodies, we have that flight or fight tendency. When we get a little bit of energy after we've rested a while, we're going to do the best we can. So you might see that higher temperatures, breathing faster, and then all of a sudden, and even more awake, at those moments. But then, oh gosh, I need a break. Lower body temperatures, more shallow breathing, resting, trying to recoup. And that's what happens. And eventually, I explain it because with my families, I say it's like a roller coaster, up and down. And as time goes and that disease process continues to get the upper hand because our immune systems are getting weaker, you're going to have more frequent times of low periods, okay? And then it's going to gradually get to longer periods of the low period, sleeping all the time, really shallow breathing, that type of thing. And that's what progressively leads to the very end. And it's all about that weakness that's leading the journey, okay? And I hope that explains a little bit of what you can experience in the very
Thank you.
beginning. Yeah, thank you.
Allison. That helps. Again, this is physical, emotional, spiritual, and Victoria, as Whitney said, we care for people. We know that some people live in individual homes like Paula, and others are in any number of long-term care facilities, and there's a range of those. And I know that's where your work mostly is. And if you could talk to us a little bit about that long-term care setting for someone who is going through a progressive, a terminal illness, both for the patient in terms of care needs and changes, for the family, and that long-term care staff who is providing the care, and how we can all work together when hospice or palliative care is involved, since we know both programs visit at all of the different long-term care facilities.
Absolutely. Thank you, Risa. And Allison, thank you for that great explanation of the disease progression and symptoms. I was listening to Stan's story and the news delivered to you all of Paula's disease. In a home setting, it's your family that gets the news, and then you and your family cope with it in the home. In the long-term care setting, you have a bigger family. They go from being our patients in the homes, but in the facilities, they are called residents. So we care for our patients, but they are their residents, meaning they live there. They are their family. So going into long-term care settings, we have to remember that the workers in these facilities, these are their grandmother, they call them grandmothers, their aunts, their uncles. They care for these, our patients, their residents, just as they're their family members. So the news not only goes to the patient, their resident, but it goes to them as well. So we care for the patient, the family, and the facility staff as well. And so that emotional support that we give to everyone, the education, the training, the symptoms that Allison was talking about, whereas in the home, it's the patient, the family that you're educating and training. We go in and we educate and train the facility staff on top of that. So it can be taxing on everyone to hear the news for the first time, and having to adjust to that can be very difficult in the beginning stages. Whether the family has just moved the patient into a facility or they've been there for a while, either way, this patient is in an environment that they've either been in or it's new to them, and we have to make it comfortable for them. We have to make it accommodating as the disease progresses, we have to be sure that they have all the things that they need. So whereas Allison was saying they're not hungry anymore, well, in a facility, that's what they have been taught to do. They are taught to offer food 3 times a day, snacks, liquids, fluids. If anybody was to come in, that's something that they would normally typically want to see, that this patient, their resident, is eating and drinking. So it can be difficult teaching that, no, they don't need that type of food anymore. No, we don't have to force that on them. Meeting the patient where they are can be big, especially in the facility. So sometimes we have where the family can help us tell the facility that. Sometimes it's us helping everybody along. But as the hospice nurse, as the hospice team, that is what we do. We meet you where you are. We take our time, we educate. But I just was hearing Stan and him and his wife, he said that they're empty nesters. So it was just them two coping with the news in the home, directly dealing with it every day. Whereas in the facility, we have a big array of people that's coping with it, even down to like the dining staff that delivers the meals to the resident. Why aren't they ordering their food anymore? Or why aren't they out in the hallway? When you talk about disease progression and not being able to get out of the bed like they used to, not going down to activities that the facility may host like they used to, it can be different for everyone. So it pulls on everybody's heartstrings, but it is an honor to be able to go in and educate and teach. This is where they're at now. This is what's going on with the body. This is why they may not eat, why they may be sleeping more, as Allison alluded to. So all of those things, we kind of meet them where they are and support them in the long-term care setting, but we make it as homey as possible, because that is their home. And I know Whitney alluded to that we have like an inpatient facility. Same thing there. They can be cared for 24/7, just like they were in the home, in a home setting. We try to make it as comfortable and home feeling as possible.
Thank you. Thank you so much. I want Misty to talk to us some about this whole emotional, spiritual, all of the feelings that are going on for Paula, for Stan, and then between our patients and our family members, our caregivers. As change happens, it's an ongoing process. And if you could talk to us about some of those things.
Thank you, Risa. Stan did an excellent job of sharing his heart story. And he also mentioned how there is a variety of emotions going on. And unfortunately, whenever the family is going through these emotions, they're not always going through them at the same time. So there's a difficulty in coming together at times, and you feel even more alone. But depending on the circumstances and each journey being unique, when that diagnosis is first given, there's denial and shock and like, wait a minute, I can't handle this. And sometimes you need to stop and take a day just to absorb it. And you may not want to share that information at that time because you're absorbing things, taking what you know in your head and bringing it into your heart, feeling those feelings that need to be felt. And as it starts to sink in, you may feel like life is unjust. You're not finished living. Why me? Or why her? Why is this happening? Like you said, she did everything correctly. So what happened? And then that will lead also to fear, which is present the whole time. Fear about what's going to happen next. Fear about, what if I mess up and do something wrong? What about, what if I start being in pain? Or what if I can't be independent anymore? And there's also a fear of the afterlife for people that believe, that have a spiritual background. And so there's a lot of searching for meaning and purpose, a lot of questioning why was I here? What do I do now? And there's also grief that the family feels for the individual that's going through the hospice experience. But there's also the patient or the loved one grieving their independence, grieving the fact that they can no longer go to the bathroom by themselves, grieving the fact that life has changed and it's never going to be the same. As time progresses, some people find peace. Some people will accept what's going on and be resigned to it. But there's others that feel like they're giving up if they don't continue to fight and continue to question and search and be angry. It's like that those emotions are what keeps them going. And then if this experience is prolonged, there is an impatience, not because you're impatient somebody's getting ready to die, but impatience of sitting in that space of pain and fear. You're impatient and you want to get out, but you don't want to get out. You feel guilty for wanting to get out because that means that your loved one has died. And there's also that numbing fatigue and that you mentioned, that presenteeism. You're going about life, but you're not really, because there's so much going on inside of you. And there's also that frustration of not getting enough sleep, of not knowing what to do, of not being able to support the patient, or for the patient for not being able to figure out how to best do this. And that's just a lot of different emotions going through your heart and your head. And like I said, spiritually, there is a spiritual aspect for those who believe in God. There's a lot of questioning during that time, or a lot of rethinking about their belief system and readjusting as well.
Thank you. And I know that, there's so much in this, in this conversation, and so many, we could spend an hour with each one of you. But I want to turn to a question that one of our participants has submitted. And Whitney, maybe you can take this. It says, looking for some clarification about palliative care, about how palliative care and curative care can coexist in a treatment plan for a particular patient. And we know that we can have palliative care and curative care going on at the same time. So can you talk to us a bit about that?
Yes, so I can use a specific example. We had a number of patients that were diagnosed with cancer and were receiving various types of chemotherapy or radiation, and also were palliative care patients. I know we work very closely with the Cancer Center here in Burlington, and they have a palliative care provider actually in the Cancer Center. And the reason is because part of palliative care, like I said, you can start at the beginning of an illness or a diagnosis, and actually that would be preferred, because we don't know where things are going to go or how your treatment's going to progress, or the illness will progress. So we have to be a part of that in that conversation, and or we want to be a part of that conversation, because we want to know what the patients want, what the family wants. How is this going to look? What are your goals for treatment? What does this look like for you? Or what symptoms are you having? I mean, some of our patients that were receiving chemotherapy and radiation had a variety of side effects. And so, working with the palliative care team to address those, because those are causing some issues for you, and maybe leading to more things that are preventing your continued treatment. So how can we address that? How can we continue to move forward? So palliative care is more of a larger, I guess like an umbrella. So they're trying to address different things. It's not of the mindset of, we're at this point where no more curative treatment, no more anything pursued in terms of cure, but more of, how can we make this better? How can we support you and your goals where we're at right now? And that can progress throughout that entire illness until that time comes where it may need to be switched over to hospice because, various reasons. The patient decides that they're done with treatment or the treatment just isn't working. And so that may be, there's not a specific time for anybody. There's no point where they say that's too much treatment. Palliative care is hands-on and can be if patients and families want them to be a part of that entire time.
Thank you. And thank you for that question. And if others have questions, please submit them. I think that I have often heard, both palliative care and hospice care, we're talking about the alleviation of suffering. And that is truly what we are addressing. And we know that suffering comes in many ways, physical and emotional and spiritual. And so both programs are separate, but they both have that common goal of letting the patient tell their story and the families and the caregivers. And Victoria, I'm thinking the residents, when we're thinking about long-term care facilities, not every patient can stay where they are because if Paula at her initial entry into palliative care was in an assisted living or even independent living, as the illness progresses, staying in that setting might not be possible. So can you tell us some about how we support people when they might need to have increased levels of care? We know we put more services in the home as we can, but in that long-term care setting, tell us about that.
Absolutely. Thank you, Risa. Yes, you're right. As the disease progresses, we do all that we can with the goal of trying to keep the patient where they are, the resident where they are. It can become times where either the pain is uncontrolled, they need a nurse 24/7. Some of our independent living and assisted livings don't have a registered nurse or someone who is certified in certain things. So yes, it comes a time where we may have to move them to our inpatient home. I have also seen circumstances where a patient was in an independent living, needed a higher level of care. Maybe they need help moving more now, or they need feeding assistance and they have to go to assisted living as their needs increase. I've also seen assisted living patients who may not quite be at that few weeks, like Whitney was saying, to get into our inpatient, but they need a lot more care such as feeding. They need maybe a lift to get up out of the bed. Then they have to be moved to a skilled nursing facility. In our skilled nursing facilities, there are 24/7 around the clock caregivers and a nurse on duty to help with the symptom management as well. But yes, as the level of care raises higher and higher, sometimes we can't prevent the move, but we still, hospice goes with you wherever you are.
Thank you. We have another question about when your loved one is adamant about not going into hospice, is palliative care able to be present throughout the dying process? Is palliative care beneficial to the dying person? And, Stan, you found benefit, I know you said, from palliative care, and in truth, palliative care supported you and Paula through truly the vast majority of her illness.
Yes, that is one of the beauties of palliative care. It is a little bit of a two-sided coin, and working with providers like AthoraCare, I found that this to be the case. So the upside is that palliative care's main job is to alleviate pain, symptoms, and suffering, as Risa mentioned earlier. And it can be extremely effective at that. Paula didn't really have some of the, even though some of her chemotherapy was really aggressive, she didn't have like severe nausea or some other side effects that some people go through with that. So she was, until she had like the cracks in her spinal cord, she was doing okay. It was more fatigue and some other symptoms that medications, things like massage and Reiki therapy that often can be part of a palliative care treatment program, other therapies, were really helpful. One of the big things, though, that I think when a person, the patient, isn't willing to accept hospice care and they stay on palliative care until the very end, yes, they can get alleviation of the pain and symptoms. But I'm getting into the brass tacks here. The hospice Medicare benefit is so much more robust than palliative care. And seriously, the family and the patient can benefit, usually at no cost to them, with things like medical equipment, supplies, all the prescriptions that are related to the hospice diagnosis. There's so much more support that's available and paid for through hospice that frankly isn't covered and paid for the palliative care benefit. Palliative care really depends on the expertise of the team, and it's often delivered in a very effective manner. But there's just so much more that the team can do if someone becomes a hospice patient.
Thank you. So Allison, maybe give us to sort of piggyback on that. We know that we respect people and where they are, and sometimes the patient is at a different place than the family. And certainly we look to our social workers, our chaplains, and our entire team. But tell us some about just a brief overview when somebody is in hospice, that team that comes around them, but also the other services in terms of assistance with bathing and medication and supplies, just sort of that benefit, that package of services that hospice provides.
Yes, that's right. I am part of a multidisciplinary team, me or the nurses, the social workers, chaplains, what we call hospice aides, which are the CNAs, doctors, clinical managers. And that's what I love about hospice, is because we pull all together and we look at the patient and the family and their multiple needs and say, okay, what can we do to help them through this journey? Okay. And we listen to where they're at. Now, we don't force things on them. We let them know what's available. We make recommendations and we continue to support them. So with hospice, we're going to visit a lot more frequently than with palliative care. And you could have like a hospice aide or CNA come in and help with the bathing during the week, and we will discuss how frequently that is needed. And I always say these CNAs just make you feel like you've been to a spa. So it really helps these patients feel so good, because these CNAs, they have a nurturing about them that makes you feel very special. So that's just a wonderful benefit that we have. We also have the benefit of providing medical equipment as needed. Things can be costly. So when our patients are so weak and they're no longer walking, they're become more bed bound. So we can get a hospital bed, and that's so beneficial in so many ways to the caregiver, because you can adjust the bed, and to the patient for other reasons, to help with breathing and all these other things. So the medical equipment we would supply, any medications that are related to the primary terminal diagnosis, they would be covered at 100% if they are listed on the hospice formulary. If not, we can make adjustments accordingly. The chaplains will come in frequently for the support, social workers, and we all get together as a team every week to discuss our patients. So it's really just an all-inclusive type of thing. It's really beneficial and helpful.
Thank you. And we have one other question, and Misty, I'm going to ask you to take this, and just the reality of the caregiver who feels like calling in hospice means that they're giving up on their loved one. How do we deal with that reality, that feeling?
It does in some ways feel like you're giving up, but it also, you have to remember you're trying to do what's best to be able to support life and living. And we want our loved ones to be able to experience life at the highest level possible for as long as possible. And with that hospice support, they're being supported and held up. They're being able to express their emotions. They're being able to say, this hurts, help me. There's just such a big, robust group of people coming in. And always, you have the fact of knowing you can just decide you don't want hospice anymore. If you are just so afraid and so upset, that is always an option. So it's not like, oh, once I take hospice, I can never revoke, because you can. Why would you want to? But you can. And two, hospice is not going to keep you if you are no longer eligible to be in hospice. So it's not like we're going to keep you in a place where and not tell you, you are plateauing, you're doing great, you could graduate from hospice. So hospice is there to support you, not lock you in. And I think that would be the thing to share with people the most.
And thank you for that. I think about this webinar series really bringing light to the reality. We know that we can't change the progression of an illness, and but we can give support in the best way at the right time for each patient and family in the best way that we know how. And it's challenging. And so, Stan, as we look to the end of today's conversation, knowing that we're going to come back together next week, I wonder, as you think about that period of time when you were, being physically present at work, but emotionally distant often, and Paula was having her own experience, what are some thoughts that you'd like to leave us with in terms of what you want caregivers or patients to know, having walked in those shoes?
Two things I will summarize. One is, and Misty just mentioned this, there can be these feelings of guilt of giving up on your loved one, but I'll say it in 2 words: don't wait. My condensed version of the story, what I was talking about, just the exhaustion and the decline of Paula, I told that, in 5 minutes or so. This was a 2-year period. 2 years is a long time to go through that kind of stress. 2 years is a long time to go through that kind of pain. 2 years is a long time to go without sleep. So even if you are a little afraid of the H word, and some people think that hospice, if I go to hospice, it means imminent death. It does not. And so many hospice providers can do so much more upstream from end of life that don't wait to reach out to providers to see what kind of help they can provide. And teams like yours are so good, Risa. If you don't provide that service, you have all the connections to the other community resources, sometimes, disease-specific resources. So do not wait to reach out to see what can be done. You are not giving up. In fact, you are engaging earlier in a way that could be so beneficial to your loved one and to yourself. And that's my second point. Don't neglect what providers like this can do for you as the caregiver. I had such a short time that Paula was on hospice care, but even the time that we were in the inpatient unit together, the support from that on-site staff was unbelievable. And even if you're on care for a while, most providers provide respite care, which literally means they can come in and give you a break, and caregivers need a break. So in short, don't wait to reach out for help, and don't wait to see what they can give to you as the family caregiver in addition to the patient.
Thank you. And you raise an issue, which is that anybody can pick up the phone and call. Some people have the sense that they have to wait for a provider to make the referral to palliative care or to hospice. Yes, a physician order is ultimately needed, but anybody can pick up the phone and call our office. If you're in another part of the country or state, call and just say, this is my situation. Are you able to help me? And how can you help me? And when we get those phone calls, we are the ones who can help figure out, is palliative perhaps the best program, or is hospice? And when hospice is appropriate, it certainly does have that rich level of services that are available that are not available in many ways in palliative. Although for many people, palliative, that is just so invaluable. And with palliative and with hospice, the sooner we can become involved, the better. So thank you for that takeaway. Thank you to our panelists. You are just spectacular. And because this is a conversation we want to keep going, the panelists are going to join us again next week. So I hope the participants, you all are able to join us next week as we continue this conversation. And we really do talk a bit more in depth about when somebody is very close to the end of their life and the issues that both the patient and also the family and the caregivers may be experiencing. So everybody who registered for today's webinar will get an email tomorrow. That email will have a recording of today's webinar. If you want to watch it again, share it with others. There's also some links in that email of community resources. As Stan mentioned, we've put together a couple of resources that may be helpful to those of you out in the community. So you'll be able to make use of that. And then you can register for part 2, and we'll come back together next week and continue our conversation. So thank you again to our panelists, and for those of you who have joined us. This is not an easy conversation, but it is a very important conversation. And I wanted to share as we close a quote that struck me. It was written by Carrie Otis, and what Carrie said is, life is full of change and uncertainty. We know this, we experience this on a daily basis. And I think that holds true when we are navigating a serious terminal illness. So I will leave you with that thought and look forward to coming back together next Thursday to continue the conversation. Thank you very much, and have a good rest of the day.
Thank you.